Everyone, and welcome back to the Psychiatric Mental Health Nurse Practitioner Review. Today we're going to talk about child and adolescent disorders. So when we're looking at our assessment and care planning for children, it's really important that we develop a trusting relationship with the child to put them at ease. And we want to make sure to interview the child and the parent separately. And that's because this can provide information on internal systems within the family or internal symptoms that the child is experiencing. Also, if there is any type of abuse or things like that going on, the child may not disclose that if the parent is around. We want to always attend to the developmental needs of the child, and we're going to go through this later. But we also want to remember that cognitive delays and things like that, the developmental needs may not always be based on age. It might be based on kind of functioning. And again, that comes with the cognitive and language abilities of the child. And then we want to do a mental status exam where we reflect on these developmental milestones. We want to establish an area of kind of like a play environment and in order to open the communication with children. Children often communicate better if it's in a play type setting. You'll see this if you work in child psychiatry or with children. A lot of the time when they're doing kind of one-to-one assessments with children, there will be games and toys and things like that. And conclusions must consider age and developmental process. We can look at things like, are they dressed appropriately for the weather outside? Are they dressed appropriately for their age group? And gait and motor behaviors can also be based on age. We want to look at the parent and child interactions so we can observe them even when they're just in the waiting room. We want to examine the way the parent and child talk to one another and the emotional overtones in that interaction. And we want to look at when there is separation or reunion with the parent and child and how the child reacts to that separation or reunion. We want to look at speech and language. So do they have kind of normal, appropriate language for their age, their comprehension, word selection, and range of vocabulary, and their rate, rhythm, latency, their tone, and spontaneity in speech. We want to look at mood and affect. So mood is a verbal admission of feelings. So a lot of times this can be quotes, right? If you ask the patient, how would you say your mood is? They might say, I feel sad, I feel happy. That is the mood. It's what the patient says that it is. And then their affect is their range of emotions expressed. So this is kind of what you see. So somebody can say, I feel happy, but yet they're sitting there kind of crying in despair, hands in their face, right? That would mean that their affect is depressed or sad, even though they're saying that they're happy. It's not always congruent. And then thought process and content. So thought process is we want to look at looseness of associations, magical thinking. Magical thinking is normal in some age ranges of children. Are they perseverating about things? Do they have echolalia? So repeating the same statement over and over again. Ability to distinguish fantasy from reality and flight of ideas, and then their thought content. This is going to be, thoughts of harming themselves, thoughts of harming others. It can be, obsessions about certain things or also perceptual disturbances. We're going to look at social relatedness. So how the child responds to you as an interviewer. Their motor behavior, so coordination, activity level, involuntary movements, tremors, tics, unusual asymmetries in their body. We want to look at their cognition and their intellectual functioning and problem-solving abilities, and then their memory. So we can test their recall after 5 minutes. So we can kind of say, we could be talking to them and we could hold up a pen and we could say, I want you to remember that pen, table, microphone, right? And then in 5 minutes, we can ask them to repeat kind of those 3 objects that we had referred to earlier. We want to look at their abstraction. So assess on expected normative behaviors for age. So children ages 12 and younger are not expected to have abstract thought abilities. They can have proverb testing, so the ability to explain figurative speech. This is how we look at abstract thinking. And similarly, testing requires prior exposure to concepts, word choices, and the ability to think abstractly. So for example, we can ask them, what does the grass is greener on the other side mean, right? That's going to require abstract thinking and kind of understanding a figure of speech. We also always want to take into account like different cultures, right? So, or, if English isn't first language, right, there can be some people who maybe wouldn't understand that statement based on, different cultures and language abilities and things like that, but it doesn't actually mean they can't abstractly think. Judgment and insight. So we want to see the child's view of the problem and their understanding of what they can and can't do about it. And then therapeutic care planning. So again, there's a lot of play and art and bibliotherapy, storytelling, behavioral therapies, interpersonal therapies, cognitive therapies, milieu therapy, and then, of course, psychopharmacology if needed. So when we talk about developmental milestones, these are kind of like the big milestones for ages, for when this chart is for when they're under 4. So they should begin to babble by 5 to 7 months. They should be able to sit alone for 30 seconds at 6 to 10 months. They should start to have stranger anxiety 8 to 10 months. They should say mama or dada from 10 to 12 months. They should start walking anywhere from 1 to 1.5 years. They should start to be able to kick a ball from 1.5 years all the way up to 2.5 years. They should start to have 2-word sentences from 2 to 3 years. And speech intelligible to people not in frequent contact with child 75% of the time. So that would be around 3 to 4 years. So now we're going to go through the different developmental stages and what we should sort of see. I wouldn't get too hung up on memorizing everything from this slide, but just like the main points. So in the preschool age years, we should see children being able to dress themselves. They should be able to ride a tricycle, skip, catch a ball, and draw, and they might have their teeth starting to wiggle. Us as nurses or nurse practitioners, interventions we can use with children in this age range that are related to their physical abilities are to encourage toilet training, restrict fluids after 7 p.m. if they're having difficulty with bedwetting, daytime physical activity. Naps are optional, but should be no longer than 90 minutes and before 2 p.m. And they should be sleeping 8 to 12 hours. Socially, family is really their main focus at this age. They like physical activity. They get bored easily. They have sensitivity to other people's feelings, and they have magical thinking and exhibits fears. So that is a huge point for psych. If you have a 3 to 6 year old coming in and saying, I'm a fairy princess and I hear voices telling me that I'm a fairy princess, right? That is normal because they are in that magical thinking developmental milestone. They are not psychotic, right? So that's kind of like the main point from this slide that you should take away. And they'll also develop a consciousness and connect emotions to and effects and interventions so we can reassure them of safety, especially at night where they might be having increased anxiety. Bedtime stories are helpful. Model and role play behaviors. So we want to show them the behaviors that we want to see from them. Use play to allow teaching. Transitional objects such as a toy or stuffed animal can help comfort the child and let them make some choices. And we'll talk about this later, but autonomy versus shame is around this age group as well. So that's a big milestone for them, is to kind of be able to make choices. So cognitively, they'll have increased vocabulary. They'll explore the world with why and how. They learn best by play or trial and error. We want to encourage limits. At this stage, so this is another key point, they are egocentric. So ages 3 to 6, they cannot understand other people's points of view. So we need to keep that in mind, right? They'll have more reasoning, but not logical thought process. They do not understand a cause and effect, but they are curious, and they have short and fleeting attention spans. So what we can do is to give them directions that are short and simple, assist with sequencing tasks and organizing their day, redirect and limit negative behaviors, help them identify and label emotions, praise positive behaviors and give rewards, state rules as necessary, play with the child, they like games, and reassure processes are not punishment. All right, so now we're at the school age child, so ages 7 to 12. Physically, they're going to be more athletic. Their physical growth is going to start to slow. At age 10, we might see, or we should see, some sexual characteristics starting to appear, and they should have already lost all their baby teeth. Interventions we can do is they like physical challenges and competing games. And we can educate them on healthy eating habits and not put a focus on weight or diet. Psychosocial, so peer approval is starting to have an increased importance, and peers influence them socially, emotionally, and developmentally, and their identity. They start to have acceptance into groups, and it's a crucial component of their self-esteem. They look towards role models. They start to understand other people's points of view. Mood changes are common. They negotiate independence. They want to be independent, right? But they're not quite there yet, and needs to learn to cope with peer pressure. So things we can do is children of this age like to talk and engage with authoritarian figures. We can offer one-on-one time to help promote self-esteem and self-concept and create a therapeutic relationship. Movies can be used to open discussions of various topics such as bullying or feelings or conflict resolution. We can help to build self-worth and values through working with others and giving them some privacy as well. Cognitively, they have less concrete thinking, and they're able to start having more logical thinking. They understand classifications and routines. They identify memory and language skills. They learn best through discovery. Self-esteem influences the ability to complete age-appropriate tasks. They look for approval from adult authority, so teachers and family. And they know right from wrong, and they active, eager learners. They understand cause and effect, and they can read, write, and calculate. So interventions we can use is younger in this age range. The more younger end will like to measure things, art projects, use paint and glue. The older end will like board games, writing poems, songs, arts and crafts activities. They enjoy group projects and competitive mind games. They have individual cognitive abilities must be considered when selecting appropriate group activities. They like to feel useful. We can ask them for help with tasks. We can give them tasks that they can do successfully. All right, so then when we look at the adolescent, so this is going to be 13 to 18. So we're going to see physical changes in appearance related to puberty. They'll have increased appetite, enhanced coordination. Their adult teeth will start to be there. And then they'll have an increased need of sleep, so 10 to 12 hours. For interventions, they might need education to help them understand changes and develop good grooming and hygiene habits. And exercise is good for stress reduction. Psychosocially, they consider themselves to be independent. They want to be involved in decision-making, yet they're still dependent on their parents. Peers are the primary source of influence and support, and their peer group solidifies. Degree of self-esteem influences their risk-taking behaviors, which is very interesting, I think, meaning that if they don't have great self-esteem, they're probably going to take part in more risk-taking activities. Sexual identity and issues are to be expected. Mood changes related to hormonal changes are common. They apply their own values and morals to situations, so they understand right and wrong. And right and wrong, according to society's terms, is not as important to as how they feel inside. They develop their own identity and they have a strong need to maintain control. So interventions is they communicate an understanding of this teen's feelings when setting limits. So when you're setting limits with a teen, you want to say things like, I can see you're upset that I won't let you go out late night with your friends. And then because that's going to make them feel validated and understood, even though they don't like what you're saying. Limits provide structure and clarity related to behavioral expectations. Teens have a very strong sense of fairness that influence their perception, and it promotes self-respect and respect for others. We want to always consider cultural influences and information of health, reproductive health, and substance abuse should be given as needed. And then cognitively, they're going to have increased executive functioning, able to use hypothetical deductive reasoning to solve problems. So that is the big one for this age range. They're able to have hypothesis deductive thinking to solve problems. So if you see a question on the exam that is asking about making a hypothesis and what age you would expect this to be in, this is your answer, or something above this age range. They understand cause and effect. They see social values of issues. They have abstract thinking, so they can think of past experiences and future consequences. So again, this is a big red star for this one. Abstract thinking, you're going to see that in adolescence. They have formal, logical, and decision-making. They're egocentric, so they look deeper into themselves and see what they desire and how they can achieve it. They consider consequences, they choose their own values, and they think about the future. So interventions we can do with this, so therapeutic groups based on cognitive ability and processing skills. Abstract thinking allows them to see different perspectives. Hypothetical scenarios and role playing allow staff to explore situations and create an open discussion on problem solving, coping, and conflict resolution. It allows them to participate in treatment planning. We can treat them more like an adult than a child and respect their opinions. We want to avoid authoritarian approaches. This does not work well in this age group. And then encourage them to ask questions. So special considerations. One size does not fit all. All behaviors, positive or negative, have meaning or serve to meet the needs of the individual. Natural consequences may not always produce change. We want to help the child to gain better insight into their behaviors, choices, and outcomes that may enhance their understanding of themselves. And children with a history of trauma may demonstrate a regression in some previously achieved tasks, such as toileting or communicating. So that is a big one. Just because somebody is, 7 to 12, they might go through a traumatic experience and start to have magical thinking again. You could even see this in a child who is 14, right? Goes through a traumatic experience, starts having magical thinking. This is common. I see this in practice and things like that, right? People who have trauma, you might have a 13-year-old that thinks they're a mermaid or something, right? Trauma. So that's that. All right. So everything we just talked about is on this slide in a more organized format that can easily be printable and referred to. This is also going to be in the packet that you can easily print. It's just a nice condensed format. So developmental red flags. So at 2 months old, if they do not respond to loud sounds, they do not track faces or lights around the room, they don't smile back, does not bring their hands to mouth, unable to hold their head up while on their tummy, this is not good. 4 to 6 months, if their eyes do not move symmetrically in all directions, if they do not push their legs down when placed on a hard surface, if they show no affection for caregivers, have difficulty bringing things to their mouth, not making noises, no ability to roll over in either direction, very rigid or lax muscle tone, no laughing or squealing sounds. 6 to 8 months, no attempt to get things in reach, no interest in exploring, no babbling, or no kind of making noises. 9 months to 1 year, unable to bear weight on their legs, unable to sit up, not babbling, not playing back and forth games, does not respond to their own name, doesn't recognize familiar people, does not look where you're pointing, does not transfer toys, doesn't from one hand to the other, does not crawl, cannot stand, doesn't search for things that are hidden, no single words, no communicating gestures, no pointing at things, or losing skills that are previously acquired. All of these are developmental red flags. 18 months to 3 years, if they can't walk, they don't point at things, they don't know things that are familiar, they're not copying others, they're not interested in the caregiver leaving or entering the room, they have trouble with stares, they're drooling, unclear speech, cannot work with simple toys, no pretend play, not speaking in sentences, poor eye contact, does not work well with others or with toys, does not understand simple instructions, or does not want to play with others, sorry. And then 4 to 5 years, if they can't jump in place, they have trouble scribbling, no interest in interactive games, ignores other children, resists dressing, sleeping, using the toilet, cannot retell a favorite story, unable to follow 3 commands, doesn't understand same and different, doesn't use me or you correctly, restricted emotions, withdrawn, an attention span is less than 5 minutes, cannot tell real from make-believe, overly interested in one activity, cannot give first and last name, doesn't use plural tense properly, doesn't draw pictures, cannot brush teeth, wash hands, or undress without help. All of these are red flags. 6 to 12 years, if they're very timid or have extreme aggression or easily distracted and can't concentrate for more than 5 minutes, little interest in other kids, kind of aloof, responds to others superficially, rarely uses fantasy or imitation, restricted emotions, sad most of the time, trouble eating, sleeping, toileting, unusually passive, cannot understand a 2-part command, trouble dressing or undressing, poor impulse control, doesn't respond to positive attention, very nervous, excessive adult approval or attention, scapegoating or ignored by other children, suspicious or mistrustful, low frustration tolerance, and cannot adapt behaviors to different social situations. And then 13 to 21 years, if they're lacking secondary sexual characteristics, poor motor coordination, lack of peer relationships, cannot think hypothetically, again, that is a big red star for their developmental milestone, does not consider consequences, cannot empathize with others, cannot problem solve, does not question or reject parental standards. So, kids that are slightly defiant in teen years, or at least like questioning their parents, right? That is normal. That's normal. They want to understand. Internalized moral code, emotional or behavioral problems, indecisive, lack of concentration, drug or alcohol use, no sense of self, lacking individualization, chronic guilt, failure to plan or set future goals, and setting unrealistic, grandiose goals. So this is a nice chart. I love charts that gives you the diagnostic criteria for ADHD. And then also the diagnostic criteria, more so what you'll see related to adults, and then conditions that present with ADHD-like symptoms. So they are going to have a persistent pattern of inattention or hyperactivity. So not everyone that has ADHD has hyperactivity. It could just be inattentive. So they could become able to sit still and just say, like, I can't focus. That would be the inattentive type. That interferes with functioning or development is characterized by 1 and or number 2. So it's going to depend. If they have the inattentive type, and again, they can have both, but if they have the inattentive type, they're going to have greater than 6 of these symptoms for more than 6 months. And if they're Under 17, it will be 5 or more. So careless mistakes, difficulty sustaining attention, does not listen when spoken to directly, does not follow through on instructions, difficulty organizing tasks, avoids tasks with sustained mental effort, loses things, easily distracted, and forgetful. The hyperactivity type, so again, same number needed. So greater than 6 if over 18, and greater than 5 if over 17. So fidgets, leave seats, inappropriately running or restless, unable to engage in leisurely, quiet activities, uncomfortable being still, talks excessively, completes other sentences, difficulty waiting to turn, and interrupting others. So these symptoms were present prior to the age of 12. They're present in at least 2 settings. So that is the big one. You may see that on the exam. That these inattentive or hyperactive symptoms need to be present in at least 2 settings. So it usually would be, if they're talking about kids, like school and home. Okay. And then in adults, we want to rule out other disorders that are similar to ADHD, so major depressive disorder and general anxiety disorder. Take careful developmental history prior to the age of 12. Obtain information from collateral such as parents or school records, and assess for functional impairment. Conditions that present with ADHD-like symptoms, they are all listed there. I'm not going to read them out loud. The point is just, if people are telling you that they're inattentive or hyperactive and they think they have ADHD, they may, but they may also have one of these other things going on. All right. So when we talk about ADHD inattentive type, those inattentive symptoms dominate. And we went over that. Hyperactive, the hyperactive dominate, or impulsive symptoms dominate. And some people will have a combined type. So etiology. So biopsychosocial factors contribute to the development of ADHD. Polygenetic neurobiological deficits are associated with ADHD. So problems with executive functioning, abnormalities of the fronto and subcortical pathways, so that frontal cortex and basal ganglia. So interesting enough, stimulants actually stimulate that frontal cortex at the front of your brain. That is why some people who take stimulants may start like hallucinating and things like that. Is really stimulating that frontal part of the brain. But if you're somebody who has ADHD, it actually makes the frontal part of the brain look like a normal brain on brain scans, because they have abnormalities in that frontal cortex that make it not as activated. They have abnormalities of reticular activating systems and structural abnormalities that produce neurotransmitter abnormalities. So dopamine dysfunction, norepinephrine dysfunction, and also serotonin. So this ADHD occurs in 5% of children and 2.5% of adults in the US. Boys are more likely to be diagnosed than girls. The average age of onset is 3, with the mean diagnostic age of 9. Approximately 60% of clients have symptoms persistent into adulthood, and inattention symptoms are more persistent than the hyperactivity or impulsivity symptoms. Risk factors include genetic loading, so pregnancy and prenatal complications, family conflict, environmental as low birth weight, neglect, a foster placement, alcohol exposure while in the womb, and temperament. They usually have reduced behavioral inhibition. So assessment, again, big red star, yellow star, needs to be assessed in 2 settings. So again, home and school. They may have minor physical anomalies at higher rates in people with ADHD than the general population. So more likely to have wider set eyes, highly arched palate, or low set ears, higher than average accidental injury rates. And on a mental status assessment, we'll see restlessness, inattention, distractibility, overproductive speech patterns, affective lability, poor memory, poor concentration. So an assessment tool that can be used for ADHD is called the Conners Parent and Teacher Rating Scale. And if the child's kind of T-score, so the overall score, is greater than 65, that supports an ADHD diagnosis. So you can see over here, questions include, angry and resentful, difficulty completing homework, fights, stomach aches, argues with adults, fails to complete assignments, loses temper, irritable. So all of these different questions that they will score, and then we can come up with a diagnosis. Another assessment tool is the Vanderbilt ADHD Diagnostic Parent and Teacher Rating. So the teacher rating has 35 questions plus 3 on academic performance and 5 on classroom behaviors. And the parent questionnaire has 45 questions. So you can see them both here and all of the different types of questions that it assesses. All right, so treatment of ADHD. There are either stimulants or non-stimulant medications. So when it comes to stimulants, the central nervous system stimulation by serotonin, norepinephrine, and dopamine, these do have a potential for abuse. These are things like there are a ton of different ones, which are over on the right side. You can see all of those different FDA-approved stimulant medications. When we prescribe these, we want to assess cardiac history before placing patients on stimulants, as they can increase heart rate and blood pressure and have an increased risk of heart attack and stroke. Amphetamines are approved for ages 3 and older, and methylphenidate are approved in children as well. And then side effects include they can have a growth restriction, stomach pain, loss of appetite, weight loss, mood changes, feeling nervous, fast heart rate, headache, dizziness, insomnia, dry mouth, tics, nail biting, and sometimes psychosis because we're stimulating the brain and increasing dopamine, which causes psychosis. So signs of stimulant abuse: insomnia. If they're having insomnia, we can suggest that they take the medication earlier in the day, or we can also prescribe them something that may help with sleep. If they're having tremors, increased blood pressure and heart rate, agitation, palpitations, anxiety, irritability, mood swings, elevated mood, and again, high abuse potential. So all of these are really side effects, but if people are misusing them, we're more likely to see them. So non-stimulants, there is one called Strattera. This is approved for children 6 or older. And then we also can use clonidine or guanfacine. And here is another nice chart because I really like charts. So medications commonly used to treat ADHD, and we can see a list of them there. And then the dosing, non-stimulants include Strattera, Wellbutrin. I will note, even though this says Wellbutrin is a non-stimulant, it does have a slight stimulating effect on people. And Quellabri. And if we are treating ADHD in adults, we want to rule out comorbidities that stimulants could worsen. We want to use extended release formulations or consider non-stimulants. We want to incorporate planned medication holidays if they want, so like skipping weekends. And we can include non-pharmacological interventions such as help with organizing, planning, and study skills. So some more non-pharmacological management. So behavioral therapy, patient and parent cognitive behavioral training programs, psychoeducation, treatment of learning disorders, family therapy, and education. We want to be able to reduce, stress, self-blame, social isolation, embarrassment, depressive reaction, or marital discord if they're an adult. Typical family concerns, so stigma, anger, concerns over treatment options, the presence of controversial information in the media. So, there are claims that dietary choices cause this disorder, or beliefs that family systems cause this disorder. Family education might be needed, and environmental structuring. And then also any family educational needs, so stress management, smoking or substance use rates, poor relationship building, school issues, psychiatric comorbidities, or environmental structuring. Common comorbidities with ADHD, so major depressive disorder, bipolar disorder, anxiety disorder, oppositional defiant disorder, substance abuse disorder, tics disorder, and learning disorders. And when it comes to screening tools, and you're going to see this again in our lecture on how to remember different screening tools, the CRAFT screen for substance use. So this is looking at 6 questions, and an answer of yes to 2 or more can indicate a potential substance use disorder. So indicates a potential, right? We have to always assess more. This is just a screen. So the first letter stands for CAR. Have you ever ridden in a car driven by someone, including yourself, who has been high using drugs or alcohol? R stands for relax. Do you ever use drugs or alcohol to relax or feel better about yourself or fit in? A is alone. Do you ever use drugs or alcohol by yourself? F is forget. Do you ever forget things you did while using drugs or alcohol? F is friends. Do your family or friends ever tell you should cut down on drinking or drug use? And T, trouble. Have you ever gotten in trouble while you were using drugs or alcohol? Another assessment is called the HEADS assessment. This is for adolescents, and it assists clinicians with screening for psychosocial factors that influence the physical and emotional health of adolescents. So H stands for home. Who lives with the parent? Where do you live? Does the teen have any privacy and changes in family dynamics? E is for education. What is their academic progress? Any concerns from teachers, skipping school, plans for future after high school? A stands for activities. What does the teen do after school? Do they have television, cell phone, or video games? It is recommended that that screen time is less than 2 hours a day. And who does the teen spend time with? D stands for drugs and drinking. So normalize by saying, many of my teen patients tell me that they sometimes try drugs and alcohol. What are some things your friends talk about? Non-judgmental approach, explore benefits and consequences, and suspected habitual substance use disorder by a teen does not have follow-up, constitutes a safety issue, and requires breaking confidentiality. S stands for sexuality. Normalize and talk about patients' friends first. Consider the possibility of same gender attraction or experiences gender uncertainty or confusion. Involving teens in the discussion might approach various scenarios and mental health. So screen for depression, sadness, irritability, sleep problems, worthlessness, and guilt, and assess how relationships are affecting this. All right, so age-specific assessments. So children, they may ask questions like, or we can ask them questions like, what animal would you most or least like to be? Who would you take to a deserted island? Besides more wishes, what would you wish for if you were granted 3 wishes? And these can kind of give us specifics into how the child feels about certain things and their wants and needs in life. For adolescents, we can ask things like, what would you most like to change in your school, home life, among your friends and family, or the world? What do you see as unfair in your life? What is fair in your life? And what are plans for the next 5 or 10 years? Or what do you want to be when you grow up? So now we're going to talk about some specific childhood disorders. So oppositional defiant disorder is a child-specific disorder. We don't diagnose this after 18 years old. You will find with children, we don't really like to diagnose personality disorders like borderline, antisocial, narcissistic, right? Because the child is still developing and there is a lot of influence from the home environment and the family symptoms that may be diagnosed as a personality disorder in an adult. In a child may be a manifestation for something that they can't escape from in the home, right? When you're an adult, you can oftentimes escape, change your life, have some accountability, things like that, right? Children don't always have that option. So with that said, the first thing we're going to talk about is oppositional defiant disorder. So oppositional defiant disorder is an enduring pattern of anger or irritability and argumentative, defiant, or vindictive behavior lasting at least 6 months with at least 4 of the associated symptoms. So losing their temper, touchy or easily annoyed, angry or resentful, arguing with authority, actively defies or refuses to comply with requested rules from authority figures, blames others, deliberately annoys others, spiteful or vindictive, defiance, negative, hostile, and verbal aggression. So when we think about oppositional defiant disorder, I want you to keep this disorder in mind because I'm going to bring it back up later when there is another disorder called conduct disorder. Sometimes people say, how can you tell the difference? And we're going to get to that when we talk about conduct disorder. As just a preface, conduct disorder, you're going to see more antisocial traits, right? But we don't diagnose antisocial personality disorder in children. You're going to see more of like wanting to hurt others, like more of things like that, where oppositional defiant, this is more of like an angry mood or like an irritability. So this is more mood based versus kind of personality based. So we'll talk more about that when we get there. So let's stick to oppositional defiant. So causes, it could be the child's temperament. It could be parents who model extreme ways of expressing emotion. So if they live in a home where a parent, screams at them and uses somewhat physical violence to reprimand, you may have a kid who at school uses bad language with lots of anger that is defiant with authority because that's what they're seeing at home. They may have trauma and they may have unresolved conflicts. It's more common in children with parents who have a history of oppositional defiant disorder, conduct disorder, ADHD, antisocial personality disorder, mood disorders, or substance use disorders. It affects 3.3% of the general population, more common in males, and about 30% of children with ODD will develop conduct disorder. So our assessment, we want to do a detailed assessment of the history of present illness, including time frame, progression, and associated symptoms. We want to look at social history, including living situation, education, alcohol, tobacco, and illicit drug use, medication use, both over-the-counter, alternative supplements, home remedies, initial and periodic functioning, history and physical assessment, validate history with a family member, and then substance or alcohol use. And a lot of the assessment for all of these real disorders in children, or really any psychiatric disorder, our assessment is fairly similar, right? We need to get a big picture of the life, the symptoms, the things that are influencing it, psychosocial factors, things like that. We're going to look at mental status exams. So when we look at the mood in children with this disorder, we're going to see low frustration tolerance, anger, argue and lose temper, impaired concentration, and often blaming others for their mistakes. We want to have, diagnostic and laboratory findings so we can rule out metabolic causes or unidentified conditions. So a CBC, a chemistry profile, thyroid function test, B12 level. We can check drug toxicity, so like lead toxicity, and also a tox screen to rule out any substance use. Pharmacological management. So really there is not a first-line treatment for ODD. We want to really focus our treatment on their symptoms, so their mood or their aggression. It can often be comorbid with ADHD. And if it is comorbid with ADHD, we're going to want to make sure there is, some type of either psychostimulant or a non-stimulant like Strattera or clonidine or guanfacine. Those things can also be used for ADHD that are not a stimulant. And we'll talk more about ADHD in a little bit. Non-pharmacological management, so therapy is the mainstay. They can have individual, family, and, an evidence-based treatment of a child and parent problem-solving training, parent and child interactional therapy, and adolescent transitions program. All right, so now we're going to talk about conduct disorder. So this is one that sometimes people get confused with ODD, but we're going to talk about the differences. So conduct disorder is a repetitive and persistent pattern of behavior in which the rights of others or society norms or rules are violated. So again, we're thinking more antisocial personality disorder symptoms, but we don't diagnose that in kids under 18. So we use something called conduct disorder. The presence of at least 3 of the following criteria must be present in the past 12 months, with 1 in the past 6 months. So they need to have aggression towards people or animals. So bullies, threatens, intimidates, initiates physical fights, uses weapons to cause physical harm to others, physically cruel to people or animals, stealing while confronting a victim, or forcing sexual activity on somebody. They can have, destruction of property. Fire setting is a big one with conduct disorder. You'll see that a lot, or destroying other people's properties. Deceit or theft, so breaking into a home, building, or car, lying, stealing items, and a lack of remorse. A serious violation of rules, so stays out late before age 13, runs away from home, runs away from school before 13. So again, we want to be careful with this one, right? So it's there. It can be one of the 3 criteria, but, running away from home and staying out late, right? A child may do that if they don't have conduct disorder, if maybe they're in a setting in which they're being abused, right? So keep that in mind too. I mean, the big one for this is, really the aggression, destruction of property, physically harming others, child onset before 10 or adolescent onset after. So prevalence, incidence, and risk factors. So conduct disorder is more common in children with parents who have antisocial personality disorder, alcohol dependence, mood disorders, or schizophrenia than in the general population. It affects 2 to 10% of the general population, 6 to 16% of boys, and 2 to 9% of girls. Onset is earlier for boys than girls, and risk factors include genes. Typically, they'll have a lower than average IQ, and then environmental things like family rejection, neglect, physical or sexual abuse, and substance use. So again, when we look at our assessment, very similar to what we talked about in previous discussions, because our assessment is very similar for all psychiatric disorders. So we're getting the history, time frame, progression, social history, drug use, alcohol use, medication use, initial and periodic functional history and assessment, developmental history, and again, validating with a family member. So what we're going to see on a mental status exam and then also lab findings. So they're probably going to be irritable, angry, uncooperative with our assessment, an angry mood, lack of empathy or concern for others, distractible, poor insight. And we want to make sure to do a drug screen and then kind of those basic labs that we talked about before, CBC, chemistry panel, thyroid test, and B12 to rule out metabolic. Pharmacological management. So again, there's really no specific psychopharmacological management for these patients. We're really looking at symptoms and then kind of targeting those symptoms with psychopharmacology. If they're having aggression or agitation, we can treat that with antipsychotics, mood stabilizers, SSRIs, or alpha agonists such as clonidine and guanfacine. Non-pharmacological management, so a multimodal treatment program that allows all available family and community resources. Behavioral therapy is the mainstay, family therapy, and individual therapy. And lifespan considerations, so it can be diagnosed in clients age 18 or older if criteria for antisocial personality disorder is not met. All right, so let's look at ADHD. So that is ADHD. We are going to talk now about autism spectrum disorder. So autism is a persistent deficit in social communication and social interaction across multiple settings associated with deficits in social reciprocity, so a back and forth flow of a social interaction, nonverbal communication, and developing, maintaining, and understanding relationships. There's also restrictive, repetitive behaviors. So they have stereotyped or repetitive motor movements. They are very insistent on sameness. They have highly restricted or fixed interests, and they have hyper or hyposensory input. So the cause is unknown. The incidence is 2 to 5 cases per 10,000 people in the United States. Males are more likely to have it. So a 4-to-1 ratio, male to female. The disorder appears to be more common in families in which one member has autism spectrum disorder. The co-occurring rate for identical twins is 60%. It affects about 1% of the United States population, but the disorder is more common in boys. They believe it's due to an imbalance in glutamate, serotonin, and GABA. Brain imaging studies of children with autism reveal microscopic and macroscopic abnormalities of the amygdala, hippocampus, and cerebellum. They have a decreased number of Purkinje cells in the cerebellum are thought to play a role in the development. Autism spectrum disorder is more common in children with a family history of pervasive developmental disorders, and the onset of symptoms is before the age of 3. About 10% of people with autism have genetic or chromosomal conditions such as Down syndrome or Fragile X syndrome. So our assessment, we're really looking at, because this is an impairment in social interactions as part of this, we're looking at those social interactions. So how they communicate, their behaviors, abnormal gazing, so staring at somebody too long or unable to make eye contact, their posture and expression in social interactions. Lack of peer relationships, emotional reciprocity, or spontaneously seeking of enjoyment. Impaired communication, such as a delay or lack in development or spoken language, inability to initiate and sustain conversations, repetitive and stereotype use of language, and inability to play with others. And then we're also looking for the restrictive, repetitive, and stereotype pattern of behaviors and interests. So, and really kind of an inflexible adherence to specific non-functional routines. They have repetitive stereotype motor mannerisms. And so therefore their parents may report these symptoms. So no cooing at 1, no single words by 16 months, no 2-word phrases, loss of language, no imaginary play, little interest in playing with others, extremely short attention span, no response when called by name, little or no eye contact, intense tantrums, fixations on a single object, unusually strong resistance to change in routines, oversensitive to certain sounds, textures, or smells, appetite or sleep rest disturbance, and self-injurious behaviors. When we look at a mental status finding, they might have little or no eye contact, flat or blunted affect, lack of emotional reciprocity, and stereotyped or repetitive motor mannerisms. So there is a checklist called the Modified Checklist for Autism in Toddlers, or the MCHAT. This is an example of it. You do not need to memorize this for the exam, but it is here if you want to review it. Kind of gives you the scores as well. Then there is the Autism Diagnostic Observation Schedule Generic. It has, again, this is a picture of it, and these are the scores. Again, this is not something that you will need to memorize for the exam, but it is here if you would like to review it. Then there is the Ages and Stages Questionnaire. So to score, we add up all the responses to 6 questions in each area to calculate the total score. Scores should fall between a 0 and 60. They get a 0 for never, a 5 for sometimes, and a 10 for always. And again, this is kind of how it looks. All right, so pharmacological management. So again, there's no specific pharmacological intervention for autism. However, things that we can use. So antipsychotics are effective for symptoms such as tantrums, aggressive behavior, self-injury behavior, hyperactive, and stereotyped patterns. The one that is most promoted or talked about in the research is Risperdal, especially for like aggression and self-injurious behaviors. Antidepressants that and naltrexone, clonidine, and stimulants can also help to diminish self-injurious and hyperactive and obsessional behaviors. Non-pharmacological interventions, so behavioral therapy to improve cognitive functioning and reduce inappropriate behaviors, occupational therapy to improve sensory integration and motor skills, speech therapy to address communication and language barriers, pivotal response training, and appropriate school placement with a highly structured approach. All right, so next we're going to talk about Rett's syndrome. So Rett's is the development of specific deficits following a period of normal functioning after birth. There is no known cause. It is progressive and deteriorating course after an initial period without apparent disability. So the child is born, they appear normal, right, through the first 5 to 7 months after birth. And then they start to have this progressive deterioration. It's comparable with probable metabolic disorder, has genetic mutation is suspected. It occurs primarily in girls, and it's usually associated with an intellectual disability and an increased risk of seizure disorders. So again, when we do our assessment, we want to get a good picture. So we're looking at the history of the present illness, the time frame, progression, and associated symptoms. We're looking at a social history, where they're living, their education, medication use, their initial and periodic functioning history, validate all physical health findings with a family member. And we want to assess for, did they have this normal prenatal and perinatal development, normal psychomotor development through the first 5 months after birth, normal head circumference after birth? Because again, the onset is after a normative period. an early loss of social engagement, appearance of poorly coordinating gait and trunk movements, severely impaired expressive and receptive language with severe psychomotor retardation, and irregular respirations. They can have seizures, scoliosis, loss of purposeful hand skills, deceleration of head growth, stereotypic hand movements. So these are the things that we would see. There's some repeats there. So Brett's syndrome has stages. So stage 1 is 6 to 18 months, where they start to have a gross developmental delay, loss of eye contact, placidity, poor motor tone, and breath holding spells. They'll start holding their breath. Stage 2 is 1 to 4 years, where they have stereotypic hand movements while awake, irregular breathing patterns, absence of seizures, sleep disorders, and increased irritability. Stage 3 is 2 to 10 years old, where they have increased rigidity, bruxism, abnormal involuntary movements, extrapyramidal symptoms of the head, neck, poor feeding, weight loss, and increased seizure activity. And then stage 4 is when they're over 10 years old. They'll be unable to walk, have worsening trunk control, deterioration, and reduced seizure activity. Diagnostic and lab findings. So there's no specific laboratory or diagnostic finding. We do want to do our basic kind of labs. So CBC, chem panel, thyroid function test, B12 to rule out metabolic causes or unidentified conditions. We want to do a drug screen, and an electroencephalopathy and nonspecific abnormalities on brain imaging. So we want to look at that as well. Non-pharmacological management. So we as psychiatric mental health nurse practitioners do not treat this. So we refer it out. They're going to need a multimodal treatment and looking at symptoms specifically. But again, we do not do this. We as psychiatric mental health nurse practitioners are trained for psychiatric specific conditions. This is not that. All right, so let's talk about eating disorders. Eating disorders are characterized by disordered patterns of eating accompanied by distress, disparagement, preoccupation, and a distorted perception of one's body shape. So when we talk about anorexia, this is when a client refuses to maintain a normal body weight. It involves restricted caloric intake. Clients have an intense fear of gaining weight because of a distorted body image. When we talk about bulimia, so this is when clients engage in a binge eating combined with inappropriate ways of stopping weight gain. So this could be purging or laxative use. They're usually normal or slightly overweight. Binge eating disorder is a recurrent episode of binge eating with lack of control. It occurs at least 2 days weekly for 6 months, and it's not regularly associated with compensatory behavior. So typically they'll eat like a huge meal, but they don't purge or use laxatives after. So causes, it's really multifactorial with biological, social, and psychological factors. There is some neurobiological factors, including decreased hypothalamic norepinephrine activation, dysfunction of the lateral hypothalamus, and decreased serotonin. It's more common in girls with 85 to 95% of occurrences. Anorexia nervosa affects approximately 0.28 of the US population. Bulimia affects about 1%. Onset is usually between 14 and 18, and risk factors include genes, family members with an eating disorder or mood disorder or substance use disorder. So assessment, we're looking at a history of the present illness, including, again, the time frame, progression, and associative symptoms. We want a social history, the medication use, initial and periodic functioning, and validating the history with a family member. With anorexia, things we're going to see on our assessment is a refusal to maintain a minimal normal body weight, weighing less than 85% of expected weight, fear of gaining weight or becoming fat, and distorted body image. So there is an anorexia restrictive type. So during the current episode, the person has not regularly engaged in binge eating or purging, or there is a binge eating or purging type where during the current episode, the person regularly engages in binge eating or purging. When it comes to bulimia, this is a recurrent episodic binge eating, where they have a compensatory behavior that occurs at least twice weekly for 3 months. This includes self-induced vomiting, laxatives, enemas, diuretics, stimulants, abuse of diet pills, fasting, and excessive exercise. Self-evaluation unduly influences the body shape and weight. So there is a purging type where they're mostly purging or using laxatives or diuretics. And then there is a non-purging type, which the person uses inappropriate compensatory behaviors such as fasting or excessive exercise, but has not regularly used purging or misuse of laxatives, enemas, or diuretics. Physical findings for those with anorexia include low body mass index, amenorrhea, emaciation, bradycardia, hypotension, EKG changes, hypothermia, yellowing of the skin secondary to carotenemia, dry skin, brittle nails, luongo growth on the face. So that's like this very light hair that grows all over the face, extremities or trunk, peripheral edema, hypertrophy of the salivary glands, erosion of dental enamel, and Russell signs. So they'll have kind of scarring or calluses on their hands secondary to self-induced vomiting. With bulimia, the weight will usually be within a normal range. They will have erosion of dental enamel, those Russell signs, hypertrophy of the salivary glands, and rectal prolapse. Mental status findings, so they're going to appear emaciated if they have anorexia. They might have some lability of emotions, anxiety. They might be constricted and sad, have a dysphoric mood. Their thought process is they're most likely going to be preoccupied with food and body weight, low self-esteem. They might have decreased concentration, judgment impaired for self-welfare, and impaired insight. Diagnostic and laboratory findings. So again, we're doing our basic kind of blood work, CBC, chem panel, thyroid test, B12, drug toxicity screen. For anorexia, we may see things like anemia, leukopenia, neutropenia, thrombocytopenia, hypokalemia, hypomagnesemia, hypoglycemia, and decreased LH and FSH. That has to do with menses. Bulimia nervosa, we might see hypotension, bradycardia, hypokalemia, hyponatremia, hypochloremia, hypomagnesemia, metabolic acidosis or alkalosis, and elevated serum amylase. Pharmacological management, so medication management as adjunctive therapy to psychotherapy. No specific medications for anorexia. Fluoxetine is FDA approved for bulimia. SSRIs and tricyclics are effective in reducing the frequency of binging and purging. And we want to treat associated symptoms such as depression and anxiety with their appropriate pharmacological therapies. Non-pharmacological therapies, so medication and nutrition stabilization is very important. They're going to need multimodal treatment with weight restoration, correction of electrolyte imbalances, vitamin supplements, and nutritional counseling. They might need dental care because of that dental erosion. Psychotherapeutic interventions are individual, family therapy, group therapy, behavioral and cognitive therapy, and community resources can be support groups or a 12-step program. So we're going to talk about intellectual disabilities. So the onset usually develops before age 18. There's mild, moderate, severe, and profound, which are based on the IQ score. It is hereditable in about 5% of cases, related to inborn errors of metabolism, single gene abnormalities, chromosomal and X-linked gene of FMR1 or Fragile X syndrome. Early alterations in embryonic development account for 30% of cases due to prenatal exposure of toxins, and pregnancy and perinatal problems account for 10%. So fetal malnutrition, premature birth, fetal hypoxia, and birth trauma. So with intellectual disabilities, general medical conditions are acquired during infancy or childhood contributes to approximately 5% of cases. So infections, brain trauma, and exposure to toxins. There's no clear etiology, can be found in 30 to 50% of cases. And the most prevalent cause is fetal alcohol syndrome. So when we talk about fetal alcohol syndrome, you can see the picture here, some of the physical abnormalities that you will see related to fetal alcohol exposure. So epicanthal skin folds, low nasal bridge, short nose, indistinct filtrium, small head circumference, small eye openings, wide set eyes, and a thin upper lip. Prevalence risk factors in screening. So 1% of the general population, highest rates are reported in school-age children. Risk factors are genes and adverse birth events, and screening occurs at well baby exams and school screenings. So physical exams that we are going to see with people who have, like Down syndrome is pictured here. Oblique eye folds, small flattened skull, large tongue, broad hands with stumpy fingers, single transverse palm creases, high cheekbones, small height, brush field spots on their iris, abnormal finger and toe prints, cryptochitism, congenital cardiac defects, early dementia, and hypothyroidism. You can see examples of those there. They have communication deficits, dependency, passivity, poor self-esteem, low frustration tolerance. They can have aggressiveness, stereotypes, and repetitive movements, as well as self-injurious behaviors. Pharmacological management, we want to treat concurrent psychopathophysiciology, and aggression and self-injurious behaviors may be controlled with antipsychotics or mood stabilizers. Therapies are behavioral, group, and family therapy. Community resources include group homes, shelters, or daycare settings. When we talk about Fragile X syndrome, this is the overdeveloped structures with a short stature, large head, elongated face, hyperextensible joints, abnormal large testes, short structure, cross-eyed, and highly arched palate. And that was a picture of what a child looks like. Then we have separation anxiety disorder. So this is common in children, and it is covered in the anxiety section of this course. So then we have disruptive mood dysregulation disorder, or DMDD. So this is a childhood depressive disorder that is diagnosed in children older than 6 but younger than 18. The features of this disorder are chronic dysregulated mood, frequent temper outburst, severe irritability, and anger. It affects about 2 to 5% of children and adolescents, and it has a higher incidence in boys and school-age children than in girls, and often comorbid with ADHD or ADD. So the big thing for this, because this is another one that people get confused with oppositional defiant disorder. So disruptive mood dysregulation is more focused on a dysregulated mood. Oppositional defiant is more based on, like, if you tell a child to do something and they're like, no, like they're oppositional and they're defiant, but they're not as bad as our conduct disorder kids, right? But disruptive mood dysregulation is a disruption in the mood. So again, we're going to talk about this more. So assessment. Children should be screened for personal and family history of a bipolar disorder. Symptoms of disruptive mood dysregulation disorder can be similar to bipolar. So comorbidities are bipolar, ODD, ADHD, depressive anxiety, and autism spectrum disorder. So bipolar disorder is one of those disorders that we do not like to diagnose in children. So they kind of have their own specific disorder. So a lot of times DMDD could later turn into a bipolar, and that's why it can be kind of important to know if there is a family history, because there is a very big genetic component to bipolar disorder. So medications that can be used to treat and target symptoms of the disorder. So, stimulants like Ritalin, especially if there is that ADHD, antipsychotics, antidepressants, selective serotonin reuptake inhibitors, mood stabilizers, and atypical antipsychotics can be helpful as well. Non-pharmacological management, so individual, group, and family therapy are helpful. Then we have intermittent explosive disorder. So this can be in adults or children and involves repetitive sudden episodes of impulsive, aggressive, violent behavior or angry verbal outbursts in which the patient reacts grossly out of proportion to the situation. Then we have Tourette's. So Tourette's is a type of tic disorder. Tics are involuntary repetitive movements and vocalizations. Tourette's syndrome, also known as Tourette's disorder. At least 2 motor tics and at least 1 vocal tic has been present, not necessarily at the same time. Tics may wax and wane in frequency, but have occurred for more than 1 year. Tics started to appear before the age of 18. They're not caused by the use of a substance or medical condition. It's primarily caused by neurotransmitters, dopamine, and norepinephrine and serotonin. So pharmacological management, atypical antipsychotics. FDA has approved Haldol, Pimozid, and aripiprazole for this treatment. Medications such as clonidine and guanfacine can be used to help control impulses and rage attacks. Antidepressants such as fluoxetine or Prozac might be helpful for sadness, anxiety, and OCD. And non-pharmacological management such as behavioral therapy or CBT can be helpful. So that's Tourette's. So the thing with Tourette's, you have the tics and you have the vocal with it. So they're saying things that they can't help with Tourette's. With a tic disorder, they're having that repetitive, recurrent motor movement. So like eye blinking, nose wrinkling, neck jerking, facial grimacing, throat clearing, grunting, snorting. That can be a simple vocal tic. So there's vocal and motor. Gestures are jumping, touching, pressing, stomping, twirling. They can make vulgar kind of statements. They can have spontaneous expression of a single word or phrase. Those are more kind of complex. And these are all the diagnostic criteria and the treatment, which we just went over. So sleep problems. So children can have sleep terrors or night terrors. These happen in 1 to 3% of children. Sleep terrors can occur between the ages of 2 and 12, but most commonly occur between 3 and 4 years of age. They can be panicked, terrified, sweating, rapid heart rate, and breathing. It most often occurs in the beginning or the first third of sleep. They may be crying, screaming, not seem to awake or aware of their parents, may not recall the next morning. They're predisposed by sleep deprivation, illness, or stress. Management, it's usually self-limiting and reassure the parents and the kids. Safety measures such as locks, gates at the top of the stairs, and alarms, and avoid triggers of exacerbating factors such as sleep deprivation, and avoid awaking the child during an event. So nightmares can occur toddler to any age, creates a fearful situation. It usually occurs in the final third of sleep, consoled by parents' presence, vivid recall of dreams, and predisposed by stress and anxiety. Management, relaxation, cognitive and behavioral strategies, frequent and persistent nightmares require evaluation for trauma and anxiety disorder. Then we have elimination disorder. So there is encoparesis and enuresis. So encoparesis is the involuntary or voluntary passage of feces in inappropriate places. It occurs ages 4 years old and one event per month for 3 months. So primary encoparesis is when fecal incontinence in the child who has never completed toilet training, and secondary encoparesis is when it occurs in children who have been toilet trained. It's classified as retentive or not retentive. So retentive is when they really they hold it until they physically cannot hold it anymore. And then non-retentive is when they just will go kind of in inappropriate places. So prevalence is 0.3 to 8% of children. It occurs more often in boys than girls. And treatments can include laxatives, disimpactation, cognitive behavioral therapy, family education, strategies to reduce embarrassment at school. And then enuresis is the involuntary or voluntary voiding of urine in the bed or clothes occurring after age 5 twice a week for 3 months. There's primary, which bladder control was never established, or secondary, in which it was. And then treatment, spontaneous remission can occur over time, review toilet training, star chart, restricted fluids before bed. We always want to assess these kids for trauma as well. I did a project on encoparesis once and learned that there's typically a lot of trauma in these kids. So just side note. And that is the end. So thank you so much for tuning in, and I will see you guys next time. Bye.